Now here I will be discussing a very interesting decision. So if you can simply pause and try to think what is the problem in this ECG, you can take a look. So coming to the ECG again, the first thing that we have to see is to calculate the heart rate. Now into this ECG, if you see the simplest heart rate calculation method is 300 divided by number of large squares. So here 300 divided by large square is like this is the one large square and this is the second large square. So this is in short the distance between two R's or the two tips of S waves. So there are two. So the heart rate is around 150. We can simply see the same thing here, that there are two boxes, large boxes, and the second calculation is 1500 divided by total number of small squares. So as there are two large boxes, means one large box equals to 10 small boxes. So it is 1500 divided by 10 and it is 150. So heart rate is around 150. It means chances of having its sinus tachycardia or SVT, supraventricular tachycardia, is very high. So when we see very closely, we can see P waves. So you can see this is the P wave. This is the P wave. So it may look like a sinus tachycardia, but if you see again very closely, this is one P wave and there is one more P wave here. So there are two P waves everywhere. There are two P waves. So there's there is QRS. This is one P. This is second P. But QRS is single only. So there are two P waves, but QRS is only one. It means the atrial rate is double the ventricular rate. Because if you calculate the atrial rate, again we can apply the same formula. The rate is equal to 300 divided by number of large squares. So if you start here to here, it is one large square. So the atrial rate is 300, whereas the ventricular rate is 150. Means every two P waves, every two atrial rate, we are having one single ventricular rate. It means there is a block. There is a block of 2:1. Means there are two atrial complexes. Means atria is contracting twice, and then only we are getting one contraction, which is ventricular contraction. So usually this doesn't happen in typical SVT, AVRT, AVNRT. It doesn't happen. It is very peculiar feature of flutter, atrial flutter, where atrial rate may differ and patient may have 2:1 or 3:1 or 4:1 or 5:1 block also, or more advanced block also the patient may have, or patient may have varying block. So somewhere it may be around 2:1, somewhere it may be around 3:1, somewhere it may be around 4:1. And the flutter, atrial flutter, we have a very characteristic feature which is called sawtooth. Sawtooth, Sawtooth is an instrument which is used to cut woods. So this sawtooth is very peculiar in the shape. It is like this, which is used to cut the wooden blocks. So we can very easily see this type of sawtooth pattern, and it is very well visible here. So if you can see, this is a very typical sawtooth appearance. So this sawtooth appearance, two atrial waves and one ventricular wave, is a very classical feature of atrial flutter with 2:1 block. So as atrial rate is more and ventricular rate is less, very commonly blood tend to remain in left atria, right atria. That is the reason why blood stasis is much common. So blood clots very commonly occurs in this atrial flutter, especially if the heart rate is, or the atrial rate is more like 3:1 or 4:1, because the heart doesn't get pumped at all. So blood remains in the atria. It doesn't go into the ventricle as it should go. That is the reason why blood clots is very common problem. And this blood clot in the vein, heart, can definitely cause strokes, heart attacks, renal artery thrombosis, peripheral artery thrombosis. So anticoagulation is very much important if this atrial flutter is not treated optimally. So what are the drugs? Very commonly, the drugs which we use is, as this is an atrial rate, means sympathetic surge is very common. So sympathetic system activation very commonly increase the heart rate. So beta blockers, which are selective beta blocker, means heart related selective beta blockers, which actually acts at SA node, like atenolol, metoprolol, bisoprolol, carvedilol. These all can be used to reduce the heart rate, to reduce the excitatory or over excitability of the SA node. The same way, we can also use other antiarrhythmic drugs like cardron or amiodarone. Now, amiodarone is almost used in all the arrhythmias except where there is very wide QRS complex. So cardron can definitely be, usually what we use is 150 milligram. If the patient is stable, we can give diluted into 100 ml of NS. We can give it over 20 minutes, 30 minutes. And if it is necessary, we can repeat it. If it is an acute flutter, we can continue the infusion, as very commonly is cardron, which is given on infusion, is we use as much cardron as the weight of the patient for 6 hours, and then we use half of the weight cardron for 18 hours. Means if the patient weight is around 60 kg, we use 60 milligram of cardron for 6 hours, and for next 18 hours we use around 30 milligram. And after this 24 hours, if the patient is stable, we can simply switch to the oral cardron therapy. So we simply calculate how much cardron the patient has received, and very commonly around 300 to 600 milligram of cardron can be started per day if the patient heart rate is not less than 60. So cardon is one of the safest medicine to use for this atrial flutter. Metoprolol, which can be very started with 12.5 milligram, it can be given 100 milligram a day, very commonly. Atenolol in the same dosage. Carvedilol, bisoprolol dosage are a bit different. The third important class of drug which is very commonly used is calcium channel blockers and dilzem. So dilzem or diltiazem can reduce the inotropic activity of the heart. So if the patient's EF is very low, it should be preferably avoided. And if the patient has acute atrial flutter, and if the patient is symptomatic, then dilzem can be given IV also. Dilzem comes in around 25 milligram vial. So around 10 or 15 milligram of this dilzem can be taken in around 10 ml of NS, and it can be given slowly over a period of a minute or two. So while we inject this dilsem very slowly, even 5 milligram, 10 milligram of dilsem also we can see the heart rate reducing to or getting normalized in front of our eyes over the monitor. So we can simply give dilsem if the patient is stable, if a patient doesn't have any symptoms, then oral dilsem can also be started, diltiazem. So very commonly 30 milligram 3 times a day can be added, or if there is insufficient response, we can make it 60 milligram per 3 times a day. Or once the heart rate is settled over this oral tablets, or once it is settled by after giving injection diltiazem 90 milligram sustained releasing tablets are also available. It can be given twice a day. So in the future, if heart rate starts reducing to less than 60, then we very commonly reduce the heart rate. And once the causative factor for this atrial flutter disappears, like inflammation, sepsis, heart failure, then there may be a reduced need of dilsem or cardron or beta blocker. So in initial days, patient may need around, suppose, dilsem of around 180 milligram. But once the heart rate is better, once sepsis is gone, once congestive heart failure is better, so once whatever the problem which created this atrial flutter is settled, we can reduce it to 90 milligram per day or 60 milligram per day or 30 milligram per day over a period of time. The same way, cardron or amidron dosage can also be reduced over a period of time once the etiology causing atrial flutter is subsided. And to prevent the clotting, if the patient is hospitalized, either enoxaparin, that is Clixin, can be given in therapeutic dose, which is twice a day, or in thromboprophylactic dose as once a day. Usually, for any adult patient, 1.6 milligram is very commonly used. 0.6 ml is very commonly used. Or if the patient can also be put on heparin. So heparin, usually 3,000 to 5,000 units of heparin is given almost 4 times a day if the patient is in the therapeutic range. Or if we have to put it as a thromboprophylactic dosage, we can use same as 3,000 to 5,000 unit twice a day. At the time of discharge, if the patient's heart rate still remains high, suppose if the patient has cancer, or if the patient has severe hypoxemia, COPD, COAD, or significant restrictive or obstructive lung disease, if the patient has persistent atrial flutter with these type of blocks, then rivaroxaban can be used to prevent the clots. Apixaban can be used. So such novel oral anticoagulants can be definitely used. So rivaroxaban, the therapeutic dose is 15 milligram twice a day for around 15 days, and then we start with 20 milligram per day to continue. So if the patient gets much better, maybe after 3 to 6 months, the dosage of the rivaroxaban can be definitely reduced to as much less as possible, so as uh, to prevent the bleeding risk as well as to prevent the clotting risk. So this is a very typical and very nice ECG of atrial flutter with 2:1 block, and with a very typical sawtooth appearance. For now, thanks for listening and thank you.